Well, good evening, everyone. My name is Dr. Steph Dallaire, and I'm a family physician currently working in Peterborough, Ontario. I have worked as a full-time emerge physician, both in Kingston and in Peterborough, and worked as a sports physician in Kingston prior to taking on family medicine in Peterborough. But I really have an interest in concussions, and so I'm going to be moderating today's session. And we're lucky to have a few other people who are interested in concussions. So I'm going to let everyone do a little bit of an intro. So if we can start with Shannon, that'd be great.
Yeah, so I'm excited to be here tonight. My name's Shannon Kenrick-Fusho, and I'm a nurse practitioner that trained in primary healthcare. And I am very privileged to have the ability to practice with a focusing concussion with an interprofessional team with a physician and chiropractor up in Sudbury.
Great, thank you so much. And next on my screen, I see Sean. So if you can go ahead.
Yeah, thank you. It's an honor to be here as well. So my name is Sean Robb. I finished a PhD in neuropsychology at Brock University, and I practice as a psychotherapist currently and seeking registration for neuropsychology in the province of Ontario. My research actually studied concussion, so I focused on the relationship between mood disorders and concussion for my PhD work, and then I practice clinically with a group of neuropsychologists in the private sector, and I also do public hospital work focused on individuals with neurological injury and mood disorders and mental health challenges that come afterwards.
Wonderful. All right. So you're going to definitely bring in a great perspective here. Next, we have Alex.
I'm Alex Weiler. I train in family medicine, and I work in the Peterborough Emergency Department primarily. Also do a bit of work along with Steph with the Peterborough Petes as one of their physicians. So see a lot of concussions in an acute setting in those settings, and I'm very happy to be here as well and to lend any sort of expertise I can.
Yeah, it's great. It'll be great to have an emerged perspective there for the acute stuff. And we have Christian.
Hi, I'm Dr. Christian Dallaire. I'm a pediatrician in Ottawa. I did a pediatric sports medicine fellowship in Boston, and I deal with most of the chronic concussion cases. I run the Eastern Ontario Concussion Clinic as the medical director for the CHEO Concussion Clinic in the Pediatric Sports Medicine Clinic of Ottawa. I'm an assistant professor at the University of Ottawa. I work with brain and mind research.
Wonderful. All right, great. So we have a nice varied panel here and I'm hoping that it's going to open up a lot of really cool discussions. And it's going to be great to have some variety. I do have a list of questions that I do want to get through. So we're going to just jump into it's a question number one, an area that we can just discuss, and wanted to talk about what are the challenges in diagnosing concussion and in the initial management of concussion. So that's a little bit of a that I think that is almost two phases. So we might be able to break that up a little bit, but let's maybe talk about, the challenges in diagnosing a concussion first. I'm not sure. Does anyone want to start off?
Sure.
Christian.
So it's the first time I've ever used that raise a hand function. So I was kind of cool seeing a hand up there. So I think, one of the big problems with diagnosing a concussion is that there are so many other factors that contribute to concussion-like symptoms. And I think that, it's very important to get a really good history about what was going on at the time of the head trauma and, how did the symptoms relate temporally to the head injury? Because like I said, there's so many different causes of headaches and feeling tired that, one of the major issues that I see is that trying to, tease out what is concussion, what is the myriad of other factors that can cause them.
Great. Wonderful. It's interesting because I think I'm looking at the people that are involved here. We all will see patients, clients at various times. And all of a sudden I'm like, hey, you know what? We kind of start at the beginning. And I think that would likely be Alex, would probably have the most experience with right at the up front. So maybe you could talk about, the diagnosis from an emerge standpoint. because I know as a family physician, one of my frustrations when having worked in the emerge and with players out on the ice or in the field, you have various amounts of time that you can spend with the person. So Alex, from an emerge perspective, what can you share?
Yeah, so I find one of the biggest challenges is the competing interests when you're in the emergency department. When someone comes in with a head injury, concussion is kind of the last thing you're thinking about as far as before they go home. You want to kind of make sure you have that diagnosis and give them information about what's going on there. But there are first and foremost, we're thinking about the life threat. So do they have a bleed in their brain? Do they have a significant neck injury? Do they have any other traumas, or trauma to their chest or abdomen? Do they have a significant fracture? So you're kind of working down through all these different things. And then concussion, you really want to make sure you make that diagnosis. But there's so many other things going on depending on the severity of an injury. So that's kind of one of the biggest things. And oftentimes we're being interrupted as well. Like some other people were saying already, it's important to get a full history of the events, what happened around the injury. We're very limited in time in the emergency department. Oftentimes we can be working with one patient, we get called to another room to see somebody else, and it really interrupts your ability to get a full, thorough history of what happened to really say definitively, yeah, this really sounds like a concussion at the time of injury.
Yeah, and would you agree that, especially for some of the bigger, more traumatic injuries, that does come later on, once people are stabilized and stuff like that. I have to admit especially in the non-sporting injuries, it's sometimes elderly who have had a fall, and you don't think necessarily of the 90-year-old with the concussion later on. It's more, okay, is there a bleed? Let's make sure there's nothing bad. And then they're like, you know what? They're stable. And then you have to remember, wait a minute. Oh yeah, there might be some repercussions over the next couple of weeks or further.
Yeah. And talking about time course as well, they may not have developed all their symptoms that day or within a couple hours of the injury. You may be only seeing a subset of what they're experiencing, and that may progress and be a bit worse over the next little while. They may develop new symptoms that we aren't aware of at the time as well.
Does anyone have anything else?
I think we get asked a lot about why we spend so much time doing education, and I would argue one of the hardest part about diagnosis is just recognition. So we spend a great deal of time doing education with the general public to make sure that these injuries get recognized. Our youth organized sport and things like that tend to be really good at recognizing these injuries now. They've gotten a lot better, but it's also about recognizing the injuries that maybe didn't have any type of formal involvement in sport, or perhaps on the schoolyard, or motor vehicle accidents where there's lots of distracting things happening at the time, and concussion is somewhat of an afterthought when they're not getting better. So spending a lot of time recognizing it as a possibility so that early intervention can actually take place is, I think, a really important part of just getting them to a point where a diagnosis can be made.
And then, once a diagnosis, we have various tools to help us with, potential diagnoses. But in the emerge, you don't have time. You don't have, half an hour to go over or do a complete thorough stat 5, right? And we will get into tools in a little bit, because I think that is going to be an important piece of this. But then that's where I'd say the family physician then comes in. We have a little more time. All right. We're still limited, but we can book appropriately. If someone has an injury, I think we can go be a little more thorough. Once we recognize what's going on, then we might refer on to, a neuropsychologist, or like for further diagnosis. So Sean, what do you think, how, from your perspective, what do you think we can do? What would you do for diagnosis?
Well, often by the time they get to me, that's part of the challenge, is trying to figure out, was there a concussion or not? A perfect example would be like a motor vehicle collision, where a person is unsure if they had a concussion or not. And that's often a question that we receive. And we're often trying to figure out, like, did the person lose consciousness? Are they having difficulties with memory around the time of that? Did they hit their head and they're having difficulties with memory around that event? If they have memory difficulties, they may not know if they lost consciousness for that period of time. There may be this challenge of trying to know whether, I just have this gap of time, right? So I'm in this motor vehicle collision. I have a gap of time. Did I lose consciousness, or am I just not able to remember? And then if you add a difficulty of, if you saw the accident happening, you have all this anxiety that can also impede cognition. So that further complicates the story in trying to understand that. So it's a very complex situation. And I was really thinking about the idea of it would be nice to have witnesses at that time. Like if there's anyone who saw what took place, whether it be on the field or whether it be, a bystander in the motor vehicle collision, that information, if it's ever collected, and it rarely is, unfortunately, is so helpful to know what happened in that event.
Absolutely. Yeah, no, that collateral information I find is a very important piece when we can get it. Anyone have anything else to offer with regards to that diagnosis piece? Now, within the same question, we were talking about also the initial management, and we know that the course of the concussion is very fluid, and we have, this longitudinal aspect where we need to, we have some things to watch for and some things to work on, I think, throughout the recovery period. Now, I think, again, we could start at the beginning with from an emerge standpoint. What is that initial, what do you tell your patients after that initial, or athletes, you're on the ice and you maybe witnessed a loss of consciousness, you've stabilized, you feel the patient is okay, and now they feel not very well. Now what? Alex, what would you say there?
Yeah, the first thing I usually start with is giving them some reassurance so first telling them what a concussion is. Usually I'll have a handout to kind of hand them so they can kind of have a piece of paper to take home with them so they can, a lot of the information people get in the emergency department, they don't always remember the words you use. So having a piece of paper to go home with is often very helpful. I'll usually give them a handout. We have an OBIA handout that kind of goes through what a concussion is, red flags, reasons to return, and kind of the first few steps as to what they should be doing. And so I just kind of go point by point through that. Usually I'll tell them majority of people are feeling much better within a month. Like over 80% of people are recovered by a month to 2 months, and depending on the patient population, that can vary. And then I tell them sort of what I would generally recommend is 24 to 48 hours of fairly almost complete brain rest, just taking it very easy, not doing anything particularly physical, and really focusing on the mental cognition aspect of things. Because a lot of people, I think everyone has a pretty good understanding that if I have a concussion, I shouldn't be out playing sports. I shouldn't be putting myself in danger of being hit again or doing anything particularly physical. But I think a lot of people default to, okay, I can't do something physical, so I'm going to be on my phone a lot. I'm going to watch TV a lot. I'm going to do all these other things that are just as damaging for concussion. So I try to make that a point. And then I tell them after that 24 to 48 hours, if you're feeling better, start advancing your activities. Even at 48 hours, if you're not completely better, you still have a headache, you're still feeling nauseous, still having trouble focusing, you should start doing some things and start pacing yourself back to normal activity. So, and then I kind of outline what that means. So start by doing 10 or 15 minutes of an activity, whether that's reading or watching TV or going for a walk, and take a break and see how you feel after that. And if you felt great, perfect, take a little break. Later in the day, do a bit longer. If you felt your headache come back on or get more severe or feel more nausea, then you're doing too much and you need to back off maybe to 5 minutes at a time and then kind of go from there. It's kind of my initial discussion.
Perfect. Now, Christian, when do you usually see patients in that timeline?
Yeah, so I just want to add to what Alex said, and Shannon said something earlier. I think, some of the most important initial managements is the education piece. So Shannon alluded to that, and that's so important, getting good information out there. And then kind of to add on what Alex said is painting a positive picture of recovery. There's actually been studies that have shown that, if the ER doctor can kind of give some good education and importantly, paint a positive recovery. All you hear in the media now and everything about concussions and this a life sentence, when really like 85% of them, like Alex was saying, can be better within 2 to 4 weeks. So, really what the perception of concussion is not always as accurate. So when patients actually are reassured and say, all right, these are the steps that you take and you should get better kind of progressively and sequentially, then that can go a long way to having a therapeutic effect too. So for me, so as a pediatrician, it's considered a specialist, and so to come and see me would need a referral. So, normally I would get a referral if the patient isn't recovering like they're supposed to, and so they need some other options, maybe a second opinion is when another, would be a family doctor, sometimes an ER doctor would get referred to me, and then it takes a month or two sometimes to get into me, but again, in my office, when we get a referral, we do try to reach out to the patients and give them some of that initial good advice. I have a wonderful nurse that really good at giving some concussion education that tries to paint that posture and give some initial generic steps to help kids get better. But often it's the kids that see me are the ones that have had 6 months, a year, 2 years worth of symptoms, or haven't been in school for a couple of months and just need a little bit more direction. So there's a lot of a lot that kind of transpires between the head injury and the time that they get the.
And Shannon, what about you? It sounds like maybe you would see almost in that middle period between the emerge and that more chronic, people that still have persistent symptoms.
Yeah, so we see a bit of a mixed group because we'll see them straight from emerge, especially with sport-related injuries, or kids that have been at really high risk who have potentially had multiple injuries, and we are trying to avoid that prolonged picture, and we'll accept those referrals earlier. Part of the reason for that is simply to get them doing the things that we know will support that recovery picture and not have them think of the fact that because I've had one concussion, this is going to be a much longer recovery, et cetera, to try and avoid that. So say after that 24 to 48 hours, we focus on getting them back into the routine, back to school. My team will tell you I'm a bit crazy about school, about getting kids back into their routine. Little kids and teenagers, it's important for them to socialize and not isolate. And then in our more persistent cases, it's very much like what Christian said, is we're there to try and rule out, make sure that we aren't being tricked, make sure that this is in fact related to concussion and confirm that diagnosis and there isn't potential for something else going on, and provide lots of reassurance about how to manage symptoms, how to actively rehabilitate symptoms and get them sort of set on the right path. So education and reassurance is kind of standard regardless of when we're seeing the patient, and then the rehab obviously differs a little bit based on where we're going from there.
Yeah, I have to agree with the importance of that reassurance piece, and I'm sure all of us have stories of telling someone, you're like, no, you know what, you can get better, and their faces just light up. They're like, really? I thought I was being condemned to a lifelong injury or whatever. But as soon as you say, no, most people, you're going to feel not well for a while, but most people recover fully, and you're going to get back to doing all the things you love to do, and it's going to, without any concerns. And I've heard a few stories, and I've certainly seen patients like this. I find that there's kind of two groups of patients where you have to, some people you need to encourage to go a little more aggressive with getting back out there. And then there's the ones where you're like, whoa, we need to slow down. And I forget who it was that mentioned it, but I think I remember hearing something about hawks and doves. And, you usually have to figure out who am I dealing with. And I'm lucky as a family physician because I do get to know my patients and I know who they are, how they usually, perceive the world around them. And try and find that happy medium for them. They're like, okay, you know what? You're ready to get back out there. Let's just do a little bit more. All right. Now with that initial, I guess, Sean, you would probably come in maybe a little bit later in that picture as well. Do you find that you're seeing more people with persistent symptoms, or are you helping out a lot with the diagnosis?
Most of my work would be with persistent symptoms. Many times I rarely see a person that hasn't had symptoms for at least a year. but often it's multiple years sometimes that they're experiencing challenges. So for sure, my experiences are predominantly with persistent symptoms and trying to help people figure out, like, are these symptoms going to stay, or are these symptoms and we just need to figure out the right strategy for a person, or do we need to shift gears and think about compensatory strategies, as in maybe the brain is a bit different now and we need to build a new user's manual for you because things are a little bit different than what you expected. The brain that you grew up with is a bit different. And you can build this new user's manual and still build a really meaningful and hopeful life in that regard.
Oh, I like the way that you said that, new user's manual. I'm probably going to steal that. Now, I also want to touch on a little bit about, some of the specific challenges in diagnosing various populations, but more specifically children, and teenagers. Kristen, as a pediatrician, what would we have trouble eliciting sometimes information from the child, especially if there's been no witnesses of what's happened. How do you approach those things?
I just got to unmute there. So pediatric population, I think it's unique on a number of different levels. I think with everything in pediatrics, we always say that, kids aren't just little adults, right? And I think with head trauma, it really does, it plays a role there too. I think there's so many different variables that the developing pediatric brain, is different than the adult. So, one of the first things, that we do when I see them is to rule out some of those other conditions. Right? So one thing that I always say is when we get head trauma, often we get these concussion blinders on, right? Where they get hit and all of a sudden every symptom that they might have has to be related to concussion. So, we forget about ruling out some of those other things. So, often we get, blood work looking for, other things, whether it be low iron or thyroid issues or, even mononucleosis. But the diagnosis that I've made coming to me is, concussions that did not get better as we expect. I could write a book, all the different things that, can play into it. And so I think one thing that's really important to rule out, the other factors. And then one thing we do is we just really get down to basics as well too, is with kids is and Shannon kind of alluded to it again too. It is so important for these guys not to kind of take on that sick role and not feel sick and not expose them to another trauma. Like they had a head trauma and that's one, but social isolation, pulling them out of sports, I mean, that's trauma, and it can really start taking a toll. I think you look at the kids and I always call teenagers, it's almost like an evolutionary faux pas, right? Where, their brain is developing, their bodies are changing and they have so many different stressors from school to home and, there's gender identity issues now, social isolation issues, and with the pandemic, and they just don't have very many coping strategies. And a concussion has such a big impact on every aspect of their life. Their friendships, their sports, their school, their work. I mean, every part of their life is affected by the head trauma, and such an impressionable time as well that I think, in dealing with these concussions, especially in a pediatric patient, you have to really look at it from a holistic approach and say, all right, well, let's look at all these different aspects of their life and try to adjust them, accordingly.
Great. And Shannon, do you have anything to add to that?
Well, I think teachers sometimes cringe when I say this, but I say kids in school is really important. And for the first couple of weeks, I don't care if you learn anything. And they kind of look at me and I can tell which parents are teachers immediately when it comes out of my mouth. But I say that the notion of that is very similar. It's to say that's their routine, that's their socialization, that's their structure. It's so many things beyond just sort of a simplistic cognitive rest approach to get them back into those things. I also think it's about really educating these kids about what some of their mentors go through. So when we hear teens that are saying, well, this NHL player, NFL player, they were back on the field within 5 days. And I say, yeah, they were. And they're getting paid lots of money with a huge huge team to do that. So even saying that we expect 4 weeks to be potentially a normal recovery, and reassuring them that if it takes that long, it's still okay. And also reassuring them that it's not, there's like 3 strikes you're out is not true. It's about some reassurance, because we've seen the opposite of what can happen with kids when they've been pulled out of sport and didn't necessarily need to be. And that's specific to sport. So it's really about reintegration, normalizing recovery, and not letting them fool you. I will very much echo that from Christian's perspective, that if there's something that doesn't seem quite right, you can't let them trick you. It may not be concussion. It's important to figure that out, especially with everything that's going on with teenagers right now.
And has anyone ever had a point where you question yourself? Whereas I have to admit, there's a couple times where I'm like, someone comes in with a great story and I'm already kind of going, okay, I can see where my path is going a little bit. I'm trying not to, make any prejudgments yet. But all of a sudden at the end of the day, or even after my assessment, I'm like, you actually don't have a concussion. You're good. You can go out tomorrow. And I get worried. I'm like, I don't know. Can they go out tomorrow? I think they can go out tomorrow. Wait a minute. I have no reason to keep you away from doing anything. Has anyone had those kind of thoughts?
All the time. I think, and it's so complex, and we know that we actually do harm when we make kids feel sick. And, just going back to that school angle a little bit. Yeah, I try to get kids back to school as quickly as possible, sometimes by 2 days, definitely by the 1 to 2 week mark. I really think they have to be there. And like Shannon, I always say, all right, you're there in body, but you're not there in mind, right? So again, you got to get there, but you don't have to really do anything. And you have to get, the schools on board, right? And there's been a lot more awareness over the last few years. The worst thing you can do to a kid if, he's had or she's missed a week of school, and they come back and they have 4 teachers giving them a stack of paper that's big saying, all right, this is what you have to do because you missed. Well, you can just see their concussion symptoms start to go up and up and up, right? And so now getting the schools on board, which has been a dramatic change in the last 6 years or so, where they're really on, they're really on it now and supporting these kids and giving the accommodations, which is great. But, to your point, Steph, it's, that's why I love doing, presentations and conferences and, I'm a lot of different, committees and everything, and just to talk to other people and saying, the stuff that I'm seeing and I'm doing every day, this is normal, right? And, Sean Marshall is a friend of mine. He runs the adult, clinic at, the adult concussion clinic at General Hospital. And, we talk together sometimes and we just say, all right, yeah, we're both still on the same page. This is right. This is good. And just talk to other people that do this, because, I've seen probably 6,000 concussions, and it's always just, wondering, what's the primary driver here of the symptoms? Is it the head trauma, or is that head trauma recovered a long time ago? And now it's just the fact that, the kid only gets 4 hours of sleep and, sleeps from fetal 8, or has, severe anxiety now, and that's the driver, not concussion. So it's always kind of reassessing our approach and reassessing every patient, from visit to visit and patient to patient. It's trying to, just to make sure that, we're doing right by the patient, and that you're kind of taking out that big holistic approach.
It's funny because now we have so many forms to fill out, for schools, either a stepwise reintegration into class and into sport. And I find that it's made me rethink a few things, not always for the good, because then it makes me question, the parents gave me this stack, so obviously they must have a concussion. The teacher has sent them to me to get this. And I remember the other day where I had a young kid, just a little accident at recess and a little bump. But it soon came out that mom's also suffered from a concussion and is currently, watching things. So there was that, not secondary, I don't want to say secondary gain, but awareness and worry for their child. And at the end of the day, it's like we went through it with this, I don't know, he would have been around 8 or something. And at the end of the day, he didn't have anything. He had a small knock at recess, and I'm like, no, you're good to go tomorrow. And mom was very much reassured. I'm glad she didn't play it up. They're like, well, I'm worried about this, and this. She just wanted that reassurance that, okay, he is good to go. So.
Well, the reassurance is, again, it's that topic that keeps coming up, but it's so true. I think, any trauma is bad, but I think, we do have to realize that our species is very, very durable, right? I mean, we've been getting concussions for, hundreds of thousands of years, and with that comes an ability to recover if everything else is taken care of. What I tell patients sometimes is that, our brains are very, very well equipped to recover from head trauma, because if we didn't, Homo sapiens would be extinct, right? But what we're not great at is recovering from a head trauma in this society, with all the demands and the sensory inputs and everything and all the stressors that we're all under. But underneath it all, our brains, there is that innate, well-developed ability to recover from concussion, and that's what is important.
Great. And Sean, for you, how would you treat, the difference between, well, I guess, first of all, before I go into that, what ages of patients of clients are you seeing?
It just depends on where I am. So okay. I do across the lifespan. So I do work with children, and then I certainly spend a lot of time working predominantly with adults and seniors. Okay.
Now, with regards to a difference between, say, a young adult and, the 10 and under, how would your approach differ?
Well, so I think, like many people have said here, it sounds like everyone is really trying to play detective and figure out where is the source of the problem. And I think that is very much similar to what I'm trying to do. I'm always trying to understand, why is the child or adult or senior reporting a problem, right? I'm trying to understand that. And there may be these sort of interacting factors that happen that can make it much more complicated. But for children, some of the things that I start to think about is, depending on the severity of that concussion, I start to look for not effects that are just going to happen today, but later down the road. And many of you are likely familiar with these sleeper effects that can happen in terms of executive function, where everything seems fine, for even several years. And it's not till a child gets older that they're having those more challenges with self-regulation and being able to manage competing demands and really trying to manage those situations. So sometimes I'm looking for those delayed effects that can happen with the frontal lobe and how the frontal lobe develops, right? And the same with adolescence. Adolescence is really challenging to understand because, on average, adolescents tend to be a bit more risk takers, tend to be a bit more impulsive, and it has to do often with their thinking under emotional circumstances. They can often make great decisions when the emotions are pretty low. But when the emotions are really high, it can be much harder. And so now you put an injury on top of that. How do we separate that? How do we know what the effect is from the concussion versus the effect from being an everyday teenager, right? And so those types of things become really important. And that's why we try to use tools that allow us to compare a person's performance on cognitive skills relative to people who are same age and educated matched, so that we can get a better sense of that. So that's a lot of the work that I tend to do.
It's interesting that you talk about executive function. I think everyone's a little bit brushed on how a lot of symptoms, we have to tease through a lot of symptoms. And is it actually, like Christian was saying, is it a concussion or some other type of metabolic issue going on, or is there a psychiatric diagnosis or something? And, one I find example of that where I've struggled with in the past is looking at, someone who comes, there's a lot of overlap in symptoms between ADHD, anxiety, and concussion. They all can present very similarly. And, I think it does take a lot of work to kind of, that's just one example of okay, is it more this or this or this? And sometimes I wonder, I don't know if it is this or this or this, or is it a little bit of each of these things, right? So,
does anyone have any? Sorry, say that again.
You get some of those interaction effects where it's you have a person who had maybe some difficulties with attention, and then they have, an injury, right? And we know, for example, many children with ADHD, they may have, more experiences with things like concussion, and then how do we separate them? And I think we don't always have to separate them. I think sometimes we can just work with where the person is at. But there are some subtle differences in the way that attention works based on what we think about concussion or mild traumatic brain injury versus, for example, ADHD, or the types of attentional difficulties that come with anxiety. So, for example, in anxiety, you see this spreading of attention, often looking for threat. In ADHD, you have this sort of distractibility. In concussion, we'll often see this almost perseverative, getting stuck on things and not focusing attention, but I'm getting stuck on things and I can't shift attention as easily. So in my field, we're often looking for these very subtle discriminating effects to help us understand what to do. The big challenge in my field, though, is how do you get access to neuropsychology in Ontario that's covered, right? But that's a big challenge for a lot of people.
Yeah, absolutely. I know in smaller towns, not smaller towns, I guess Peterborough, I would call it almost a mid-size, but, we definitely, it's limited resources. And we like to think that the bigger cities have a lot more resources, but I'm not sure if that's true or not.
No, it's one of the, Ottawa's a big enough city and there's such a paucity of neuropsychologists. I wish you could just bring a neuropsychologist in and, have them on salary and have them at the kind of beck and call. But, it's just listen to Sean there and he speaks so well about, for me, it's really in the pediatric population, so much about the prefrontal cortex, right? That part of the brain that sits right here, that in kids with ADHD, it's about 2 years delayed in development, and people with anxiety, that part of the brain just doesn't fire correctly, and we know that with head trauma, it affects that part of the brain as well too. So, there's a great neurologic explanation for, why all those symptoms, are similar between the conditions, and to try to tease it out, it's can be virtually impossible sometimes. And because a lot of times it's a little bit of everything, like Sean was saying. It's a little bit of pre-existing ADHD, or maybe undiagnosed ADHD, or it's head trauma plus going through a real stressful time, and so the two things together just causes this kind of, this explosion of symptomatology. And so for me and the approach that I take in trying to help these kids is really, it all comes down to quieting the mind. And that's why I tell patients a lot about, this Brain and Mind Research Institute. I love the title because within like 5 words, it wants everybody to know that there's a big difference between the brain and the mind, right? I explain that the brain's the hardware and the mind's the software. The brain's the phone, the mind are the app. They work together, but they're different. And so when you get a concussion, there is a brain injury. The hardware is definitely impacted. But to me, almost the bigger of the two evils is what happens to the mind when they get caught in this trauma cycle where, they get hit to the head and they have headaches and they have problems with sleep, and that causes problems with school, and then that problem causes problems with sleep, which gives them more headaches and more problems with school and then more problems with sleep, and then we take their sport away from them, that causes some stress, and then they're sleeping worse, and that causes more focus problems, it causes school. They just start cycling and cycling and cycling. So, my approach is just, all right, let's break that cycle, right? Let's try to, get that mind quiet down. Let's make sure that your pain is well controlled. Let's making sure that, you're sleeping well, you're eating well, and try to do whatever we can to kind of temper down that stress response that happens. So really the stress center of our brain, that amygdala, gets activated with head trauma. And I think it's our job as healthcare providers really to try to temper down that stress response, all those stress hormones that are flowing, just, they cause headaches and they cause problems with focus and concentration and mood issues. So I think, I explain it, I do a ridiculous amount of talking with patients, and I'll draw things out, explaining that my drawing ability is about 5 years of age, but, I draw a very crude brain, and then I kind of bring the mind into that, and as much education as the patients can take, I'll give it to them. I start seeing the kids kind of gloss over. I say, all right, probably talked a little bit too much, let's take a step back. But no, it's just, I think it's so, complex dealing with these head injuries. The brain, 90 billion neurons in there, and it's just, it's almost like a puzzle. Each patient is like a puzzle. Right? So never boring anyway.
And, I guess I often question, does it matter whether we differentiate sometimes, what the cause is? And Sean alluded to it, or do we just treat the symptom? And I think that definitely comes, a little bit later. But there is a time where we do say, okay, well, this is what we're now going to make this management. This is your new, I don't want to say new brain, but how you mentioned, I forget how you worded it, but I really like the way that you did about the user manual, like how, we're going to work with the symptoms you have. So I think it's not just the psychiatric component that we were just alluding to now, but with everything, whether it be sleep and function and relationships or whatever. Shannon, how do you guys approach that? Because I know you guys you have a team up there that work together. And how would you work as a team for that?
Yeah, so I admit that I'm a bit spoiled because when it comes to getting fooled and stuff, I have immediate colleagues that we get to bounce things off of each other, which is a very nice position to be in. And we do. I also subject people to my terrible drawings, which 5 is the latest that my art peaked for sure. But we try to get into a scenario of explaining to them that their picture is unique, and we need to look at what can we do to target your symptoms, go back to the basics. We call them the grandma rules, to say this is things that your grandma probably told you to do, and also highlight for the fact that if concussions happened in a bubble, everyone would get better. They never do. There's a whole bunch of things spinning around there that you also have to address, and addressing those symptoms individually and getting them to take their whole life down a notch is really important. I equate it to the classroom for kids. I say, think about how well you learn when you're with a teacher that you really like and you feel really comfortable with. That's pretty easy. Now, your brain with a concussion is like you in a classroom with a teacher that you find extremely intimidating, and it can't focus and it can't necessarily hold things as well. So we need to calm that whole system to be able to manage that intake and get you back to doing lots of things very easily, and more practice of that makes other things easier.
Okay, yeah, I like that. It'd be interesting, to see how Alex would, kind of when he's coming and the patient needs, a diagnosis of, is this a concussion or is this not a concussion? And it'd be interesting to see how he addresses that. If the kid, is supposed to play in a tournament and needs to go back the next day to play, or, how would Alex kind of, approach that, and how does he feel about putting that label on a concussion when, it's a little bit early to tell?
Yeah, it's definitely a tricky situation, especially when kids are in sports, and especially high-level sports. There is this pressure and this will to get back on that as quickly. So we were talking about how sometimes you see patients and, actually this doesn't sound like concussion. Everything seems normal. But with these athletes, there's always a bit of are they not maybe giving me the whole truth? Are they holding back some symptoms? Are they kind of minimizing what they're actually experiencing? And so, especially when there's kids who are playing sports, or if they've been injured and they're playing the next day, I'll always kind of err on the side of caution. I won't say like this is definitively a concussion, but certainly I would say that some of your symptoms could be related to concussion, or you had this hit to the head or this force to the head that could be causing a concussion. And this may not be a concussion, but I think play tomorrow would be putting yourself at undue risk. And I would say you should be following up with another provider. Someone don't necessarily have another provider, but should be reassessed or see how things are going before you go back on ice. So in the emergency department, we often don't make a diagnosis for a lot of conditions, not just head traumas. We have a lot of abdominal pain not yet diagnosed, or chest pain is not yet diagnosed, and same thing for head trauma. I'm happy not to tell someone that they have a concussion if I can't say that definitively, and I usually will give them clear instructions as to reasons we should see them again, or who they should be following up with before they put themselves at risk of another head injury.
And I'm just curious, given that we work in the same city, but what are your instructions for people who don't have another care provider?
Yeah, that's we definitely have a lot of patients like that in here. So, right now with the pandemic currently, there for children 5 to 21, there is this Holland Glory clinic in Toronto that will see youth through Skype essentially, even for the first visit. So that we have that temporary solution for youth, but beyond that, pandemic's not going on, or people older that don't fit in that age group. I spend a little bit more time with them, kind of outlining, here are the steps, here's what I expect. I point them to more resources like Parachute and some other resources on the pamphlet, this OBIA pamphlet that we have that has some links to some other resources that they can access to educate themselves further as well. But I take more time to kind of extend out my plan as far as not just the next few days to week, but here's what I'd be expecting over the next couple of weeks. And if things aren't going as we expect, we want you to come back and see us, or if there's no other option. So I spend a little more time just kind of outlining the steps and things to watch for. And especially if it's a young person, having the family there and making sure everyone's aware of the situation, not just you're telling a 13-year-old, a 14-year-old what's going on, but that someone else is there to gather that information as well.
Yeah, and there seems to be a lot of more research coming out with regards to serial follow-ups with someone who can see a progression, making a good, seeing where things are going, giving that encouragement. Okay, I think you're ready for this next step, or maybe you need to pull back. And really, often it's just answering questions. Both in Sudbury, Ottawa. I'm not sure how your areas are doing with regards to primary care follow-up. And in Peterborough, that's who we would typically rely on. What happens in your areas?
So in Sudbury, we see a lot of patients from walk-in clinics, and part of our initial assessment, unfortunately, with these people is often sometimes just a couple of serial visits to say, yeah, you actually are doing as well as we expect at this point, and that's really all that's needed. We will try, when we can't see patients as quickly as we would like that are in that type of scenario, we try to get them and recommend they try to see someone routinely, like try to visit the same walk-in clinic, so at least they have an idea about visit over visit. It becomes a bigger issue when we have out of area patients that are referred without primary care, because a lot of the time those are coming from smaller, more rural and remote communities that actually don't even have access to walk-in clinics and are dependent upon something like the emergency department for continuous follow-up, which I worked in. That's where I started my career in Emerge. So I appreciate that it's not a great place for that type of care. So it is a big challenge. And I would say the more rural and remote, the bigger the challenge we have with that as we see patients initially and transition them back if we think we've reached maximum care.
I joke that in the smaller, more rural places, there's so few physicians. If you're going to see someone at the Emerge, you're going to see the same one anyways. So it ends up being serial visits. What about in the Ottawa area? Is it family docs that are usually, following along? And
that's the goal. So I made it a point to try to really educate family doctors community. By and large, family doctors are completely 100% capable of managing these things, and that's how we want it to be. And because the family doctor knows them best, and they know kind of mitigating factors, right, for the recovery, and I think that's the key. And when that's not possible, well then we say, all right, well, let's go to the same walk-in doctor. I mean, sometimes for the more week-to-week basis, sometimes the use of a good physiotherapist, right, and kind of help guide in terms of, all right, well, this is the kind of physical activity that you can be doing. But I think that it is incredibly important to have the MDs kind of overseeing everything so that they can pick up something that maybe the physio or a chiro isn't trained to do. I think it's important to have the MDs involved. But a lot of the week-to-week basis, I think a lot of it can be managed by a good, highly trained physiotherapist that has a good communication with an MD, and then progressing through some of the final steps is and offering additional support to the medical doctor.
I'm not sure if you're all familiar with one of my favorite resources, the CAT Online website. And I actually wrote it down because I never knew what it stood for, but it's Concussion Awareness Training Tool. Well, one thing I liked about their model, and it was based out of BC, I believe. A lot of, I'm not sure who started the program up, but it sounds like it was a lot of out of the Children's Hospital of BC. But the model is that either a primary care practitioner, whether it be a GP or a nurse practitioner, as kind of the center quarterback of care, who does the major component of follow-ups, diagnosis, management. And then when you run into trouble, then kind of referring off to specific with regards to specific issues. So whether this is more of an MSK thing, is it sending someone to go see a physiotherapist or a massage therapist, like with headaches and things, chiropractor, or if it's more of some learning difficulties with school, maybe a neuropsychologist to tease out a little bit closer, like, hey, what are we actually dealing with here? So I do like, I really do like that model. And it's not because it makes the GPs in the middle, because we don't necessarily always want to be there. But I think the model does make sense. And hopefully that is if we have enough primary care practitioners out in the community. So, and I know a lot of Ontario is having issues with regards to that.
I think that's key. I think, the major guidelines out there, Parachute and the Ontario Neurotrauma Foundation, they make it pretty definitive that you need that kind of MD, because we're, really the ones that can identify, all those, kind of, other influence, and nurse practitioners as well too, that, the MD nurse practitioner needs to be at that center to really determine. I think, there's kind of an inherent problem in the system when you can, go see somebody that gets paid money to treat a neck, and they're the ones saying, oh, just need to treat that neck more and more and more. There's, same thing with the eyes, right? So that, some people are saying, oh, prolonged concussion symptoms come from the eyes. And I think, all things have a place, but at the end of the day, I think that more impartial, most trained nurse practitioner MD role is kind of the quarterback of it.
Yeah.
Sorry. From a capacity perspective too, and we really enforce this in the north. Although we'll see some cases acute, we can't see everyone. So somebody's got to see the 80% that is most likely going to recover in that first 4 weeks, and that is primary care. And reassuring that that's really the place, and supporting that, we've put lots of time into, and doing training about that, and how can we better support that, because the reality is there isn't capacity for every single person with a concussion to come and see a specialized team. I think it doesn't really even matter where you are in the province to say that. So it for sure, that primary care is so important to really managing the majority of these cases.
And right there, I'm going to put in a plug for the UHN's ECHO program. Because it does, well, it's been really beneficial, especially for people who don't have access, to this educational piece. I think a lot of primary care practitioners need some updating, and to stay on top of stuff, because I've heard all kinds of, a variety of approaches to, initial treatments and stuff. And it's funny that's a little bit of a segue into something that wasn't originally on my list, but I'm lucky because now I get to pick all of your brains for the questions that I've had. And, Christian, you kind of mentioned sleep a little bit. And you hear there's different thoughts, especially in the past. I think more, these days people are getting a little more, on the same page with regards to sleep, the importance of sleep, but not too much sleep. But the old adage is like, you got to wake someone up every couple hours, to make sure, they're doing okay. And I think we've all in agreement that we know that that's probably not the best approach anymore. But then also there's a hindrance on sleep with injuries, but then the importance of that. So, Christian, maybe I can ask you first, like the idea of sleep, and I just want to open that up, about the importance and approach towards sleep.
Sure. So I think, initially you talked about about waking people up every 2 hours. Well, I mean, we say that if you think that you need to wake them up every 2 hours, then you should be in a place where they can actually do something about it when you do, if you can't wake them up, right? And really the only thing that happens is, it gets them upset and it gets you upset. So it hasn't been really shown to decrease injuries or improve outcomes by waking people up. So, and then going more to the long term, I think, the way I explain it to patients is, all right, forget you hit your head, right? You take anybody that's sleeping 4 hours a day, 4 hours a night, or, is sleeping all day and wake up all night, their quality of life is going to be very low. And you look at through the symptoms of a concussion, and, someone with sleep deprivation or sleep dysfunction is going to score 3 out of 5, 4 out of 5 on most of these things. There's a study that showed up to 85% of prolonged concussion symptoms can be attributed to poor sleep, right? And so sleep is so crucial, not only, getting the right 8.5 to 10.5 hours of sleep, but making sure the sleep quality is good. I mean, I picked up some kids that, not only, they're getting their 8.5 hours of sleep, but, it's from, 1 a.m. to 9, right? Or, there's heavy snores. And so there's a degree of, obstructive sleep apnea. It happens in kids, more appropriate for adults, that we always have to look at that. But, I always explain to patients too that there's more brain activity when you're asleep than when you're awake, right? And so when you're asleep, your brain is reprocessing and reconciling all the different sensory inputs and the memories and the emotions and everything during the day. And if your brain can't get come to terms with all these things that it's kind of banked there, if it doesn't get that sleep, then it's going to eventually catch up with you and lead to, whether it be, poor sleep being the second likely cause of headaches, poor sleep leading to cognitive dysfunction, poor sleep leading to mood problems, right? There's some psychiatrists that, think that just about every mental health condition is preceded by some degree of sleep dysfunction. So, I think that just sleep is incredibly important, and that's one of the messages right at the beginning to tell these patients that you have to maximize the conservative measures, how you eat, how you sleep, how you drink, and keeping your stress down are for the most crucial things that you can do early on.
It's funny. I read a really interesting study a few months ago talking about how they taught mice to do this maze, and they had these little electrodes that measured by beeps when they ran through this maze. And then when they measured those beeps while they're sleeping, they saw the same pattern of beeps, but at 10 times the speed of when they were actually doing the maze. And they were talking about how that learning process, we learn so much, we relearn throughout our sleep. And so that's a message to all the kids out there. Sleep is extremely important. And with that, I should probably make sure my kids are getting to bed too. Sean, perfect. I'm glad you lifted your hand. I wanted to ask you about that.
Yeah, I just want to kind of add on to those perspectives there. I think sleep is incredibly important, and I think one thing that I see as a really significant sleep stealer, in a sense, is I really think about anxiety as the opposite of sleep. Like, in many ways, sleep is about synchronization of neurons and really about, in some ways slowing neurons down when we're talking about deep sleep. And you've already alluded to REM sleep being, very similar to wakefulness, if not more activation at time. And anxiety is like the opposite of sleep. It's really about alertness and being awake. And what is a person thinking about as they try to go to sleep? And so it's not just about, we often talk about sleep hygiene and trying to make sure we have a really great routine. But I'm often very interested in what is a person thinking about and experiencing just before they go to sleep. And is it possible that that's hindering their sleep efficacy, so that their sleep is not as good, not as efficient as it could be, and that is then hindering some of their recovery efforts and thus making the recovery longer. Right? And so that is definitely an area that I spend quite a bit of time focusing on.
How would you coach? Again, this is more personal interest, but so what are your strategies to coaching? Let's start with kids first. Mm-hmm. With regards to who are having problems with sleep.
Absolutely. So often I'll ask a child, what do you think about when you're going to sleep? What is on your mind? what were you doing just beforehand, right? So, even some of those basic principles of like, well, I was playing a video game right beforehand, and it was, something really activating, got me really pumped up, and I was really excited about it, or it was kind of scary, or it activated a lot of emotion. It's very hard for the brain to shift gears. I kind of think of it as like a transmission. And would you shift from gear 5 right into gear 1 would that be easy on a transmission? And for the brain to shift from wakefulness into stage 1 and 2 and then into deep sleep, that's very hard for the brain to do. So I often want to understand what are their thoughts doing, and can we work on slowing some of those thoughts down in advance? And I think we've already alluded to some ideas of trying to slow the system down just a bit to kind of give it an opportunity to rebuild and kind of recharge the system in some capacity. So I'm often trying to figure out how to do that. And that may be even trying to teach a child to meditate or use mindfulness approaches. And sometimes I try to avoid the language because the language has been used a lot and some people are just tired of hearing it at this point. But how do you learn how to focus your attention, slow the system down, slow your thinking down? Do you stay in bed after, for quite a bit of time when you can't sleep, right? So often ask people to get out of bed after, 30 to 40 minutes if they can't sleep. Do the most boring thing they can possibly find, right? And then wait for that sleep to come, that onset to start to happen and go back to sleep, rinse and repeat if needed, right? But it's hard for some people to do. It takes a lot of self-discipline, and sometimes it takes parents kind of coaching them through it as well.
And I think these days too, you did talk about screen time. I'm not sure about the other shift workers. I know Alex, Ian, Juan, and Shannon haven't worked in the emergent. And Christian, I'm sure you've done quite a few late nights during your career as well. But I know after thinking about this long and hard and reading up more about it, I know when I used to come home from a shift at 3:00, I'd be kind of tired, but I kind of want to unwind. So I'd turn on TSN just to watch it for 10 minutes. And next thing I know, I'm like wide awake, and at 4:00 in the morning, I'm like, geez, now I'm never going to get to sleep. So certainly changed my patterns, but we see it with kids. And I know in my practice, I have so many, there's a lot of video games going on, and, that's got to be stimulating not only for sleep, but even with concussion recovery, right? So.
Absolutely. And we kind of talk about this idea of like concussion is not just like a physical injury of the nervous system, it's also a chemical change, right? So we have this huge excitatory release, right? And are we giving that time to kind of slow the system down? So I think it's a great point.
Now, I want to get into a little bit, especially we've addressed the idea that not all areas will have access to primary care physicians. And we've talked about resources and the idea of education, how important that is. Alex talked about the OBIA, forums. Alex, do you have any emerge? Is there any other resources that you use, or is that your go-to? Or you're on mute.
That's sort of the main go-to that we have. We kind of keep a stock of those, so that's kind of our simple go-to. Everyone does their own thing as well. Like some people have their individual resource that they like to refer to as well. But that's sort of the main one that we have. And I know you mentioned the CAT Online tool. I'll mention various tools to patients as things that they're interested in learning more, especially if they don't have that primary care follow-up. But that we kind of try to keep it simple and straightforward. And emergent, a lot of the people we're seeing just really need the basic plan to kind of pace return to activity following what your symptoms are doing. And a lot of people here are seeing people later on in the time course, and occasionally we will as well. But early on, I feel like it's the basics that are, if you do them properly and explain them well, that if people are doing those things, the majority of people will recover well from that. So kind of keep it simple.
And it's funny, even with, you were talking about working with the PETs too, and we talked about how with more, with professional athletes, the drive to get back out there. But I actually see also the other side, and maybe it is with more and more with the awareness, but I find there's a lot of our hockey guys, I do have to push them a little bit, a little more aggressively, because I'm not sure if it's their managers or what who are saying, hey, we need to keep an eye on you. And it's those resources that I'm using to say, hey, no, guys, we need to follow these. We're going to do these serial follow-ups. And I'll use, the SCAT-5, because I do have a little extra time when talking with the athletes. And then we can do a serial follow-up with that too. Say, hey, look, you are getting better. You're getting close and ready to go. But when I first started working with the athletes, I was a little bit surprised because I expected to go to say, whoa, slow down. You're going to have to sit for a couple of games. But I do find there's certainly a population where I have to push them a little bit harder. Other resources. Anyone have, Shannon, at your center, what kind of resources are you guys using?
So we'll use a variety of resources that are already embedded in primary care, that especially for persistent symptoms, okay. Screening for like affective disorders and things like that. The physician that I work with and myself were involved with the Center for Effective Practice in developing their tool for primary care, which is really a collection of things that are available, which is nice, that sort of center around symptom management, sort of doing a lot of the things we've already talked about tonight, doing some early reassurance, and then targeting symptoms and treating symptoms as you would, for example, headaches, and try to identify the phenotype and treat the headache appropriately, and doing some things like that. So we've used that framework and that tool a lot with the education that we do locally. And then we use some type of measurement as a very baseline for like a persistent concussion symptom score or the Rivermead to look at tracking. I have to admit that we're lucky in the sense that even with our varsity athletes and things like that we use lots of different tools. Our assessments are generally about 2 hours long, especially for those athletes. So I say that Alex is the hardest job because he has like this much time. We have 2 hours and we can put them through the ringer. and that's important, I think, for the athletes like our amateur athletes that are playing at high levels. It either confirms a diagnosis. It's pretty hard for them to get through that if they're truly symptomatic, but also serves the opposite to say if they're actually asymptomatic, it reassures them when we're able to get through those. So it's quite a gamut of testing that looks at visual symptoms, vestibular symptoms, and doing some minor cognitive stuff, and a big basket. But I think the Center for Effective Practice sort of summarizes a lot of those tools well.
Yeah, I think that package is wonderful. As a family physician, I think it's a great resource. It's long, right? There's a lot there, and I have to admit I can't get through the whole thing in one assessment. But it gives me, if we can get through it, and I do book a longer appointment if that's what people are coming in for as a concussion diagnosis. That's all the time we have is to get through it, and then I have to bring it down. We go, okay, this is where you struggled with or had, and then we get to break it down to the areas, right? But it is tough to get through. Christian, what resources do you often use with your patients?
I think one of the best out there is the Ontario Neurotrauma Foundation. I mean, whether it's, for the patients or whether it's for physicians, it's unbelievable. So they have a living guideline there too, where, unfortunately, Ontario Neurotrauma Foundation lost their funding, so we're not really sure how this guideline is being updated, but it was wonderful. So as new studies came out, we were updating the guidelines, and but still, it's very, very complete. But concise at the same time, but just so many different pearls there that I direct a lot of people to Ontario Neurotrauma.
It really is. I agree. It's also a good one-stop shop where whatever piece you need, you can find it there. So here's hoping that we're going to be able to keep that site up and running. Sean, any resources that you frequently use for your clients?
I think most of them have been spoken about already. One thing I will add is that sometimes I encourage my clients to connect with local brain injury associations. So in my region, there's the Brain Injury Association of Niagara. And that is an association, I think, that can be a great resource. And in that association, we actually do like educational seminars. So once a month, they run a seminar for people who are either just had a concussion or they're within that kind of first year. And then there's actually a group that meets monthly for persistent symptoms that's run by one of my colleagues who's a neuropsychologist. And so that can be another great resource. So sometimes those local associations can be also really powerful places of expertise as well.
Yeah, actually, I agree with you. And I have to admit that I often, unfortunately, forget about that piece. But when I remember to go that direction, I'm like, oh yeah, they have hands-on, and they themselves know the local resources, right? Whether it's be occupational therapists that are really involved or speech language pathologists, which, we hear about physios all the time, and a lot of people will think about going that direction. But a lot of the stuff that needs to be sorted out or helped with and assessed is the occupational therapy piece and the speech language pathology piece, which for us, the way to get through it is with our acquired brain injuries organization. Just being cognizant of time, I just want to open it up if there's anyone. I think we covered a lot, and I think I want to thank you all. It was a really great conversation. I think, we did get through a lot of information there. Did I miss anything? Anything that you think is screaming importance that you'd like to get out? Any messaging?
The approach that I take with treating patients, it tends to go over pretty well. I actually use the chronic pain model, and it's that 3P model. So these are our three kind of therapeutic arms, three different ways that we can help. The first being the psychological interventions. And so you want to optimize, psychological interventions. So for that, I came up with this 3 rules of 1. And this is again more for the longer term concussions, but so 1 hour physical exercise every day, even if it's just walking, movement is good for the brain. Second rule of 1 would be, 1 to 2 hours of non-educational, non-family screen time, right? And again, very important to limit the screen time initially in the concussion, but as time goes on, letting them be a little bit socially connected, get some family bonding time is good. And then the third rule of 1 is 1 act of mindfulness. And Sean said it well. You got to be careful with saying the word mindfulness or meditation too much, because you'll see these eyes are kind of rolled back. But, I explain it by learning, teaching your, developing the skill to control your thoughts and to learn let others go and to look at things from a different perspective. And then that second P that we talked about is a physio. So these are your allied health professionals and those other products. So sometimes it's a weighted blanket for sleep, or it's saying, all right, could this person benefit from a physio or a massage or an occupational therapist or a speech therapist or, a chiro is there. So it's trying to maximize that P. And then the third P that I use is the pharmacologic. And this is where, in the right circumstances, you get a combination between supplement and vitamin and medication if need be. So that's how I kind of organize my thought. I think it's just important for patients to understand that really to get better as quickly as they can, they should kind of think of their recovery and those things. Am I doing, the most I can psychologically? Am I doing the meditation? Am I getting a little bit of exercise? And have I, gone down a path of I found a good allied health professional that can kind of work on my neck or work on my jaw if need be, and then again augment that with some pharmacological things.
Oh, that's great. I really appreciate that approach for sure. Anyone else?
The only thing I was thinking about adding is and it's been a real honor to speak with you all tonight. I think it'd be really fun to have a conversation like this about persons living with multiple injuries, right? So I think our conversation really focused on, people with their first injury, right? And then what about the multiple injuries? And some people will go on to experience multiple ones, and what's the same and what's different about that population? I think it would be really important to kind of have more of those conversations. It's unfortunate we're kind of running out of time today.
Well, I'm glad that you brought that up. And that wasn't a plant, I swear. But, today's talk was aimed at the challenges of concussion assessment and management of acute and subacute. There are other podcasts that are to come. And, so, the next one being, I'm going to read off my sheet here. So the next podcast will be a discussion of returning to education following a concussion or traumatic brain injury, facilitated by Penny Welsh West, a speech language pathologist at Parkwood Hospital in London. But I also believe there's going to be another session further along with regards to prolonged symptoms, how to help with managing prolonged symptoms. So thank you for that segue. That was lovely. But yes, thank you to all to the four of you. It's been really great. I've learned a lot, and I really appreciate all your information and the different perspectives here. So thanks, and everyone have a great night.